Welcome to the Mug Hub podcast, the ultimate platform for all things related to medicine's use, patient care, and the incredible world of pharmacy. We are your hosts, Connor and Sian, and we're thrilled to have you join us today.
Here at the Mug Hub podcast, we're passionate about empowering future pharmacists, expanding your knowledge and igniting your curiosity. Whether you're a first year embarking on your pharmacy journey or a final year getting ready to go out into practice, this podcast is designed just for you.
Across our series, we delve into 4 captivating themes that will take you on an enlightening and entertaining journey. From exploring intriguing clinical topics to showcasing the extraordinary individuals who make up our incredible teams, we're here to unlock the secrets of the pharmacy world.
So grab your favourite mug, settle in, and let's embark on an incredible voyage together. Get ready to be inspired, educated, and motivated as we unlock the vast potential of pharmacy and the vital role it plays in healthcare. Welcome to another episode of the Mug Hub, and today we are joined by one of my most long-standing colleagues, because when I started at the university I shared an office with this young man, Railton Scott, Senior Lecturer in Medicine's Use. Welcome to the Mug Hub.
Thank you very much.
You're very welcome.
It's taken a whole year to get you on this, and it was strong-arming you from the office to get you down here.
Almost quite literally. Connor and I approached Railton in his office as a duo, and there was nothing you could do, was there?
No.
Almost
Nowhere to hide, nowhere to run.
It worked. Maybe that's our new strategy.
It's effective. Welcome, Railton. Maybe we could start with you telling us a little bit what you do here at the universities, a little bit about what you do here at the university and the kinds of activities that you get involved in.
Sure. Okay. So, as you said, I'm a lecturer here at Medicine's Use. So I basically does what it says on the tin, and I lecture and run seminars and workshops, and that teaching is extended to both undergrads and postgraduate students. So it's fairly consistent, fairly busy, fairly intense, and very, very satisfying, I have to say.
Sounds good. What kinds of things are you teaching then? So like the medicine's use bit?
Yeah, so I'm essentially clinically based and clinical in my experiences and as a clinician. So I'm teaching basically medicine, so everything from renal to elderly care, and my speciality, which is psychiatry, psychopharmacology. So that's basically my remit. So I teach through the cases and, again, like I say, on the postgraduate as well. So I take them through all the various aspects of delivering clinical care.
All right, nice.
It's huge, isn't it? But I just wanted to interject and say that Railton taught me many moons ago when I was here as an undergraduate, and I think that the main thing was always about the clinical care planning and things. So such great experience, and you taught us so much about how to think about patients holistically. So obviously you mentioned all those specialties, but I think a lot of the students will probably resonate with you just being that clinician that can kind of follow a patient holistically.
Right.
That's fair.
I think that's a very good point, actually. Do you know, I just want to bring in something that was really heartening. I heard something this morning on Radio 4, and it was somebody talking about the health service, because there's obviously a lot of focus on the health service at the moment, and people talking about being broken and need for reform and everything. And this guy very movingly spoke about, he was the father of a child that was born with significant congenital abnormalities, and they didn't think that the young boy was actually going to make it through. But it was actually, he came on to say that it was going to be the young boy's first day at primary school, and he said they just didn't think that we would ever do that. The guys the little boys had more surgeries than anybody would normally expect in their lifetime, etc. But why I'm saying this is that he said, so we have dealt with oncologists, psychologists, neurosurgeons, physiotherapists, and he said pharmacists.
Nice.
Yeah, and he said, I just want to say that it's like gold standard. The NHS, certainly in our case, isn't broken. It was absolutely magnificent. And I felt a real surge there. I thought, fantastic that, along with the nurses, the oncologists, the psychologists, the neurosurgeons, etc., they talked about pharmacists as well.
Yeah. Well, certainly the role is getting more recognised. It's getting bigger. It's having more of a... I suppose, well, I don't know. Maybe I'm making this up, but
I doubt you're making it up, Sian.
Well, let's see how we go. Has more of a clinical role, but also there's a bigger public presence maybe for the pharmacists now than there was 20 years ago, 10 years ago.
I think COVID made a huge difference to that, didn't they? You became front line in a lot of cases for a lot of services for people. So yeah, definitely.
Absolutely right.
Yeah.
It's my turn to ask a question.
Oh, come on,
I'm not
Connor.
paying attention.
You're not, are you?
So
Rubbish.
You've obviously worked at the university for many years. We won't say how many. But in terms of what a typical day or a typical week looks like for you, I wondered if you could give us a little bit of insight into that.
Sure. That's I'm very much a carpe diem, so seize the day, as it were. So I get up early, and this will come as no surprise to some of the students who have seen me. I'm a bit of a guy for the gym, so I'm in the gym first thing, and then I come out to my office, and a typical day would be either preparing or actually delivering teaching sessions in form of, as I've said previously, lectures, seminars, workshops. Do a little bit of work with final year students doing their projects, so project supervision, and then a big component now is planning and delivering postgraduate module teaching. So pretty full day. And I think it is fair to say it's typical, because certainly through the academic semesters, the academic weeks, and that doesn't really change too much. So we're, as my two colleagues, Connor and Sian, would certainly attest to, it's great when we actually get that downtime when we're actually in academic break from teaching. Now, a lot of students seem to think that certainly in the summer we just leave the university.
We've got a 4-month summer,
and we exactly we go to the beach for 4 months, but that's actually not the case. And I think we probably, and I certainly can attest to the efforts of Sian and Connor, is they're probably harder work in those times when we're not actually student facing and teaching. So we do a lot of prep and a lot of sort of logistical stuff, etc. So that's kind of the typical academic week. And then I'm
going to just stop you, Railton, just because
I wasn't even talking.
I know. It comes so naturally to say I'm going to stop you, Connor. You've missed out a vital step in your day there, in between the gym and the office, is the hanging out of the gym clothing in the office.
I'm glad you didn't mention it, though.
I have shared an office, as I said at the beginning, with Railton.
That is true.
My favourite is when you hang it out the window.
I have to say, I used to share an office with Sian. I used to share an office with Mike. I used to share an office with Sephora. And I think the common factor here is that they're no longer there, but I am. So,
and the bib shorts still are.
The question, it's not you, it's me. I think it probably is me, actually. But yeah, you're right.
Sorry, I interrupted you. I think you were going to talk about a non-academic or a non-term time week. I don't know, maybe you were.
Yeah, no, I'm just saying that, so the typical week, I mean, it can be sort of split between the academic, the teaching timetable, and then when we're in the sort of non-teaching, and we do all the preparation and the catch-up and exam preparation and tweaking all the learning activities, etc. So full days, full weeks.
Yeah, there's a lot there.
Yeah, there is. And I think, so we're moving into OSPAP, the Overseas Pharmacy Programme. Yeah. We're doubling our numbers this year. So how are you feeling about that in terms of delivery, and are you quite excited to see those numbers go up?
I'm embracing the challenge. I'm embracing the challenge. But I have to say that I have been incredibly well supported by colleagues in the team. And we really are, I think, in medicine, we're really collegiate. And people have just stepped up and offered to help out, etc. And it's good. I just want to make sure that the actual experience that the OSPAPs get is not diluted, is maintained. So hopefully we will see how that goes. But I'm positive and hopeful that we'll deliver a good experience for them.
Yeah, no doubt. I think you're right. It just takes a slightly different form of delivery for some of the sessions, because obviously teaching to a group of 30 compared to a group of 100 just requires some different logistics. Yeah. But the content will be the same, I guess. And it should be good.
Brilliant. And in terms of, obviously, you've worked at the university. I can't say that again.
Oh, forever and ever.
You've been here since ages. The dawn of time.
You're so young, Connor.
In terms of how you got into academia, I wondered if you could walk us through a little bit of your career highlights and how you decided to get into teaching.
Sure. Well, it's kind of interesting and convoluted. So, just to put some sort of flesh on that skeleton statement. So many years ago, I actually first got into health by working in psychiatry as a psychiatric nurse, and then this was back in the day. So I'd got as high as I could in psychiatric nursing before there were this sort of specialised nursing roles. So the only step, once I'd got to the senior position of being what would have been called a charge nurse in those days, I was actually a charge nurse of a professorial unit looking at eating disorders, substance misuse and alcohol disorders. The Christmas parties were a hoot. So the only way I could go from there was into management, and I didn't want to do that. So the absolute truth of it is that I actually played football with a hospital pharmacist, and he said, "Railton, why don't you try pharmacy?" And I thought, "Oh, that sounds good." So I did. I came to Brighton as a mature student, or older, if not mature, way back in the day, and did my first degree in Brighton. Then went into hospital medicine, did my pre-reg in hospital medicine, and then practiced as, again, back in old money, what was known as a basic grade rotational pharmacist. And then came back to the university to do a MSc in clinical pharmacy. And then, having gained that, I went into specialised practice as a clinical pharmacist working in psychiatry. So I did that for several years, and then at that time I was actually asked to come in as a visiting lecturer to the university.
That's how it starts. It's the gateway.
Yeah. Come on.
And delivered some teaching in my speciality, which is, as we said, is psychiatry. And then that just tended to extend, and eventually I moved away from hospital medicine as a clinical pharmacist there, and then came in back in, as you say, back in the dawn of time, Connor, in 2006. So I was full-time lecturer at the university from 2006.
Oh, so you'd only been here a couple of years by the time I'd started my degree. Interesting.
Yeah. There you go.
Just 2 points, really. Do you remember Greg was talking about cricket?
Yes,
and he
know.
Got into pharmacy because of playing
that
cricket
too.
with a pharmacist.
This is how it happens. You just play sports, somebody suggests a career, it will be pharmacy, and you do it.
Yeah. And I can't remember what the second point was, but you said something else that I wanted to point out. But yeah, I guess
it might come back to you later.
It might not. And does it matter?
Probably not. No. Oh, interesting. So that's great though for our students that you've got all of that sort of hands-on experience, not only as a pharmacist but as a nurse as well. So
exactly.
Yeah.
So yeah, hopefully, as Connor kindly said, I mean, it was looking at the sort of the holistic aspects, and and having sort of like dual aspects in the multidisciplinary healthcare team, I can sort of bring it from various points.
Mm-hmm.
I mean, we always found it fascinating because I think you tell this story a lot when you start your lectures with us. So it's quite nice to hear it again. But yeah, just to kind of have that dual aspect of, you're thinking about patients in multiple ways and not just from a medicine standpoint. So
Yeah,
very, very true.
Yeah, I guess that's what helps with team working as well. And it's one of the benefits of the interprofessional education programme that runs through, well, probably most degrees, but the degree here as well, is that if you can see what other healthcare professionals are doing, it makes your job a bit easier to understand, what your role is and ultimately beneficial for the patient.
Where did you do your training? Which hospital? Was it a hospital? So that was the other thing. Oh. You're a Brighton alumni.
Yes.
We've got another Brighton alumni on the podcast.
Yes. So I actually did my first degree, which was a 3-year BSc Honours. And I always say that I came to a polytechnic, but I graduated from a university.
Did it make the changeover when you were here?
Funny. And then... again, like I say, I came back to do the MSc at the University of Brighton. But way back, I did my psychiatric nurse training in Sheffield.
Okay.
Nice.
Where's this funny accent from then? I just can't place it. We know. So what happens next then in your career and your development, do you think? I mean, Connor will say there's not much left of it, probably.
Never.
But we're constantly developing. Have you got plans for what happens next?
I think I will.
Should we just think about this week?
Retirement.
Just get through the week.
No. I think I just want to focus on giving my utmost in the time that I have left. So I just want to... People say, what do you bring and what can you give? And there are so many talented, really, really talented, and I'm not in any way being facetious, sarcastic, but some of the people that I'm working with bring so much, are so experienced and so excellent. And I mean, leaders in the field. I mean, from your clinical background, Connor, so I've learned so much from your psychology, Shan, and what you've done and everything else. So I just want to... People say, what do you actually bring to it? And I think what I try to do is try and, without being too grandiose about it, I think what I can give in my remaining time is try and be a good role model for up and coming students and graduate pharmacists, and saying, okay, this is where I come, this is what I do, this is what I think works, this is what you might want to take from my experiences and what I can go from that. So it's just doing that and being that consistent. But I don't think I'll be doing any great career development now.
You're not going to start a new degree or have a little career change?
No, I don't.
Okay, all right.
I also don't think anybody questions what you bring to the table.
No, absolutely.
No.
And I think, you are absolutely a good role model. Yeah. And the other thing I think you bring, the thing that I see you give to students, is that you care about the students, and that's so obvious in your interactions with them. And it's, it is a very time pressured job, and the fact that you can still show that level of care as well is great. So well done.
Thank you.
You're welcome.
Oh, it's back to me again. I'm just not doing very good on this one, am I?
Don't worry.
That was terrible English too. So if you had to offer a student pharmacist one piece of advice in their career or in their studies, what would it be and why?
There's two things, if I can have two.
Can we allow that, Sean?
One was...
Definitely, yeah.
One was, I remember a while ago, somebody saying, somebody asking, this was actually in a ward round, and it was the consultant psychiatrist actually asked this question of... I was sat in as my role as the clinical pharmacist, and this consultant psychiatrist just was getting a little bit frustrated with this SPR, this senior doctor, and he turned to him and he said, "How many ears have you got?" And the guy said, "What?" And he goes, "How many ears have you got?" And he said, "2." And he goes, "How many mouths have you got?" And he said, "1." He goes, "Yes, well, why don't you listen twice as much as you talk?"
Oh, I like that.
So I always remember that, thinking that
is a good piece of advice.
And the other one was, I've got a friend who is literally a brain surgeon. She's a neurosurgeon. And she said the other day, she said, "You know, Railton, I've learnt to do these complex surgeries and procedures for 20 years. And I've actually spent the last 10 years of when not to do them." And I kind of thought about that and thought, and I kind of do that with medicines, with drugs. I've spent 25 years learning all about medicines and when to use them, etc. And certainly in the last 10, 15 years, I learned when not to use them.
Huh.
So that would be.
Oh, I don't know. My brain can't take that one.
Does that fall into like de-prescribing?
Yeah, exactly.
Yeah.
Okay.
Yeah. In the pharmacy context, exactly that
Yeah.
is we're increasingly saying, you know, people that are on drugs to treat the side effects or drugs to treat the side effects of drugs, etc.
Yes.
And sometimes it's best they actually go back and stripping it all back and thinking, well, this is what we can use, but perhaps this is what we don't use.
Yeah.
And it's starting with, and again, it comes back to the holistic view that Railton has through everything is non-pharmacological. Just because we're pharmacists doesn't mean that medicines are the answer.
Yeah.
I love that. Both pieces
I like
of advice.
that. I really like
great.
that as well. My brain is just firing on something, but I don't know what.
I think that kind of falls into patient interactions as well in terms of the listening twice as much as you're talking.
Yeah.
Absolutely.
It's not a 50-50. It should be you're facilitating a conversation around what are their goals, what are their outcomes.
Yeah.
Love that.
We've got a little fun question at the end here. I don't know. Let's give it a go, whether you've had a chance to look at this. But let's imagine this scenario, Railton. You're going to a remote island where you'll be the only pharmacist or healthcare professional at all to look after a population of roughly 100 people. You are allowed to take 3 health-related items with you. What are they and why?
That's really
Noting
good.
the fact that first aid supplies will be provided.
Yeah. Okay, that's super. Is the island tropical?
It could be.
Okay. So, if it wasn't, if it was a generic sort of island, somewhere remote, barren, windswept, something like the Shetland Isles, I think I would. I kind of 3 things. So obviously, well, not obviously, but I am going to go for down the medication route, and I think I would take Wonder Drug.
Wonder Drug?
Which is aspirin.
Okay. Yeah.
So it's all the A's. It's analgesic, antipyretic, antiplatelet, anti-inflammatory. So just simple aspirin.
We've not had anybody choose that yet, have we?
We've had painkillers.
We've had generic
like morphine,
painkillers. Yeah. But aspirin
is.
Yeah, I get that.
Aspirin's a good one.
Yeah.
I like that.
And I think I'd have to, and the microbiologists are going to kill me, but I think I just have to have, as one of my 3, I think I'd have to have just a broad spectrum antibiotic. Just, you know.
Yeah.
And if it was tropical, I would take some mosquito nets.
Yeah.
If it wasn't, I would go for something as simple, but not simplistic, as multivits.
Okay.
Nice. And the reason?
Yeah, why the
The multivitamins because, we've got sort of like, vitamin deficiencies, etc. Then we could actually, everything from the vitamin Ds to the Bs and the all the rest of it. So that would be kind of it.
Brilliant. One follow-up question then. How are you going to measure the success of your interventions or of your healthcare system, as basic as it may be?
I'm going to say good morning to everybody, and depending on the number of people that say good morning back, we'll realise that they haven't died off from untreated infections. They've not been killed with pyrexia. They haven't had a thromboembolic event because of the lack of the antiplatelet effect, and they've not succumbed to scurvy.
Rickets.
Perfect. That would be it, really.
Yeah, that'll do the job.
I love that. So people alive at the end, as opposed to...
That's the most basic.
Yeah,
but
nice.
There we go.
Well, thank you so much, Railton, for joining us on this podcast. It's been really interesting and exciting to hear a little bit about your career progression.
Thank you very much for inviting me. That's great, and I really appreciate that. Thank you.
And that brings us to the end of another captivating episode of the Mug Hub podcast. We hope you enjoyed today's discussion and took away valuable insights that will fuel your passion for pharmacy.
Remember to subscribe to our podcast and stay tuned for future episodes where we continue to explore fascinating clinical topics, introduce you to incredible individuals, and enhance your skills to bridge the gap from bench to bedside.
If you've any questions, topic suggestions, or you'd like to get involved, we'd love to hear from you. Connect with us via our social media platforms or send us an email.
Until next time, keep learning, keep exploring, and keep engaging with your studies. Thank you for joining us at the Mug Hub podcast.